So let's talk first. We're going to talk about what dementia is. What is an irreversible dementia? Dementia is a term that really applies to an umbrella of symptoms rather than a specific disease. This dementia umbrella encompasses more than 100 disease processes that produce the changes in cognition that we identify now as sometimes Alzheimer's or vascular dementia. These 5 areas are the top, and I'm going to go over those a little bit more in a minute, but they're frontotemporal dementia or Parkinson's dementia, but we'll talk about those in a minute. So what is it? So it's an umbrella term, like I mentioned. It is not a specific disease. A lot of people will say, well, he or she has dementia. But dementia is a very non-specific term that describes the symptoms, not a specific disease. In the past, we used to think of it as senility. Anybody ever remember somebody saying in your family, like, well, Uncle Charlie, he's senile, or crazy Uncle Charlie, right? We would say those kinds of things. But what we really meant is that Uncle Charlie is not able to use his memory or thinking in the same way that he used to, right? And it's important to know that this is not a normal part of aging. This is not normal aging. It's not something we all have to look forward to. It is not normal. And then irreversible dementias, and we'll talk about irreversible versus reversible dementias, they are progressive. When something is progressive and irreversible, it means it keeps marching on. It keeps moving forward in spite of our best efforts. And most of these diseases that we'll talk about today do not have a cure, unfortunately. So what is the change? A lot of times people come and they're like concerned about this or that. They'll come to me and they'll say, hey, Marty, I'm not remembering names very well. And let's say it's Honora. Honora says, Marty, I'm having trouble remembering names. You see this castle that's here? You see the castle? That represents what the old is. It represents what I've always done. So I might say, Honora, have you always had difficulty remembering names? And she might laugh and say, well, yeah, I've never really been that great at remembering names. And so what we know then is this is not an old thing that has now become something new. I used to be able to remember names and now I cannot. It is something I've always lived with. And so it is a problem when it's different, when something old becomes a new thing, when we have a change from the old to something new. Wayfinding is another thing that is absolutely something that we might have trouble finding. Sometimes, let's say I've been going to the same grocery store forever, and all of a sudden I come out of the grocery store and I go, I just stop. And I think, number one, where is my car? And number two, how do I get home? If that is different, if you've always had trouble figuring out where you are in space and cannot find your way out of a paper bag, this is not a problem, right? It's a problem if you used to be great at geo-finding or geocaching and now you can't get home. So what constitutes dementia? And I'm going to give you 3 Greek words here: agnosia, apraxia, and aphasia. And the reason these are important is because it tells us what we're missing. The first one is the inability to recognize things in spite of previously knowing what it is. And you see a toothbrush there. So if I pick up a toothbrush and I say, thanks for putting this pin in my hand, I'm now going to figure out what to do with my teeth, right? That is agnosia. It's like when we think about something being agnostic, it is unknown to us. And so these are items that we previously knew what they are, and now we cannot identify them. Apraxia is the inability to carry out a learned complex series of responsibilities. So you see right here somebody putting on shoes and socks. So an example of that might be somebody putting their shoe on and then putting the sock on over their shoe. Or getting up in the morning and putting on their pajamas, or having their pajamas on, and instead of taking their pajamas off and putting on their day or street clothes, they just put them on top of their pajamas. And these are previously complex tasks that we learned that we've always known and now are unable to continue to do that. So, or we'll do it, but we don't do it in the proper order. So that is called apraxia. And the representation is the gentleman putting on shoes and socks. And then aphasia is a language issue. And aphasia can be either, I can't get my words out, I know what I want to say, but I can't get it out, it won't come out. I know the words, I've learned the words, they just won't come out. Or receptive language is, I'm listening to you, my care partner, and I have no idea, I can't translate what your words are in my brain. So I cannot get in receptive language. And that is aphasia. Dementia is the syndrome of a group of symptoms that include 2 out of the 3 of these: apraxia, agnosia, or aphasia. So I mentioned it's a wide range of symptoms. A lot of times when people think of Alzheimer's, they automatically go to memory. But it's not just memory. It is their thinking problems, their communication issues. There's an inability to pay attention to or to stay on task. There is a problem sometimes with the reasoning and judgment. People with symptoms like we're discussing today are often victims of scams, and financial exploitation is one of the biggest risks for people that suffer from reasoning and judgment issues, right? And then in Alzheimer's type, visual perception is almost always a part of that illness. For example, a person might have, how many of you parked in a parking garage today with some sort of cement pillar? So, and they're always too close, aren't they? Don't you wish they were about like a foot further apart? So a person with visual spatial issues might come too close and actually scrape the side of their car, and they do it so often that, or get fender benders, and that is sometimes an early sign that someone is having problems with their visual spatial issues. So what are the most common? I mentioned Alzheimer's type. That is definitely the most common. And it memory issues. And very quickly I'll say, let's say I'm changing out my vacuum cleaner bag, right? I'm in the bedroom, I'm vacuuming, it's not picking up. I go, oh, I need a bag. So I turn around, I go to the kitchen, and then all of a sudden I go over the threshold of the kitchen and I go like this. What just happened? What happened? I forgot what I was going into the kitchen for, right? So I turn around and I go back, and the minute I lay eyes on the vacuum cleaner, I go, that's right, okay. Because I wasn't paying attention. I wasn't attending to my own thing that I was doing, right? But the minute I see it, it cues me, I go back. I'm a woman on a mission now. I head for the broom closet. I get the vacuum cleaner bag, right? But in Alzheimer's type, there becomes an inability to retrace one's steps. So even though we're all losing our keys, we're all forgetting where we put them, being able to, it is a privilege, let me just say, it is a privilege being able to retrace your steps and find things, right? And figure out where you were last. So vascular is the second most common, and that's generally the result of an event, a transischemic, a stroke, a TIA, that especially accumulative TIAs can produce some changes in thinking. It's impaired judgment really versus memory. So you'll see people making decisions that are just a little not like their normal decisions. And it is a lot more squishy, if I can put, that's a technical term, squishy, by the way. It's a lot more squishy than Alzheimer's. Like with Alzheimer's, you kind of either remember or you don't. But with vascular, there are some events, but you may not even know the person's had an event. And so you're seeing things, there's a little bit of impaired judgment. Lewy body dementia is often found in connection with Parkinson's disease, and often there are visual hallucinations, nighttime disturbances. So these are nightmares. These are nightmares that feel like they're real. And also you can have muscle rigidity, whether or not that person has Parkinson's. Lewy body dementia will often have muscle rigidity. And mixed dementia. Mixed dementia is where a person has more than one thing at a time. That is very common. A lot of people a lot of physicians might not even say it's mixed, but it's not uncommon at all to see Alzheimer's right up against vascular dementia. And I've just said this, Alzheimer's plus vascular is really super common. And then frontotemporal dementia. How many of you have ever had someone in your life that they were so steady, and then all of a sudden they began to act very different than they ever have, right? Yes. And sometimes impulsive behavior, personality changes can happen in any of these, but it's really common with FTD. Sometimes, there was a case in the Washington Post, for example, the Washington Post magazine, where someone had a long and very credited and creditable career, and then all of a sudden was watching porn at their office computer, and was fired for that. And his wife was saying, "That is not my husband. There's no way that is going on," and was relentless at finding out what happened to him, right? What was going on. He was diagnosed with frontotemporal dementia because you do see a lot of personality and behavior changes. This is a guy who would never have done something impulsive or anything that would have embarrassed him or his family. And it also includes often primary progressive aphasia, which is both, as I mentioned before, with aphasia, not being able to get your words out and not being able to receive the meaning of the words that people are telling us. So there are other types of dementia. There are lots, and I mentioned over 100, but we're going to just talk about a few that also are irreversible. Parkinson's disease. With Parkinson's, we see executive function. An example of a genetic disease is Huntington's chorea or Huntington's disease, which is highly genetic. Creutzfeldt-Jakob, you know that more commonly as mad cow disease, but that's got a hugely fast trajectory. And then another thing is alcohol use. That is clinically known as Wernicke-Korsakoff syndrome, but it is when people chronically abuse alcohol, it is not uncommon to see that. I would also point out that Wernicke-Korsakoff syndrome is something that's often found alongside other forms of dementia. So I wanted to show you this picture of the brain for a couple of reasons. The most notable is that sometimes as care partners, we expect so much of the people that we're caring. And candidly, sometimes we think that they can do better than they are. But I wanted you to see the difference in a healthy brain versus a brain that is living with Alzheimer's. And you can see that it is significantly smaller. By the time that someone has gotten to the end stage of Alzheimer's disease, for example, their brain is about the size of an infant brain. And so it's really important for us to understand that this is a disease, and it is not something, people they're not necessarily in denial that they have got this going on. They have a brain problem that makes it impossible for them to make new neural connections. That doesn't mean that we don't have good days and bad days, good hours and bad hours when we have care, when we're caring for someone. It just simply means that when you're thinking about maybe this person is not giving me everything they could right now, or why have they asked me the same thing 6 times in a row, it helps to just remember this visual of what is happening in the brain. So I'm going to talk briefly about mild cognitive impairment. How many of you have ever heard of someone who got diagnosed with MCI? So forgetting things more often, losing your train of thought in a conversation, not getting where, like forgetting that you're supposed to be somewhere, challenges, increased anxiety in planning, maybe even moving away from what you used to do because it's harder than it used to be. I want to also thank you to the Alzheimer's Foundation of America for this information. But I want to point out that MCI is often diagnosed by primary care physicians or even neurologists because they don't want to use a term that they feel might not give people hope. And so in the best interests of their patient, in their opinion, it's better to say MCI than, let's say, early stage Alzheimer's. And so it is important to remember that there is such a thing as MCI, but not all MCI diagnoses are alike. So at age 60, about 12 to 18% of people, which is quite a few, are struggling with some changes in their cognition. The biggest change in our cognition, though, is that we process things more slowly. At age 80 to 84, it jumps to 25%. I'm not even kidding. And then it says in all the literature, NIH, the Alzheimer's Association, they say MCI generally doesn't impact your quality of life. But okay, let's face it, we all know that if something is on the tip of our tongue and we can't get the word out, we're disturbed by that. Anybody here who's not disturbed when you have that happen a few times? It's very disconcerting. It's very concerning. So, but MCI stays the same in some cases. And in some cases, it is reversible. Here are some ways that it could be reversible. Sometimes you're taking a medication that can make your thinking more slow or can impact your thinking or your memory or your putting together memories. Also chemotherapy, if you're being treated for cancer, it is very common. How many of you ever heard the term chemo brain, right? So, or brain fog following COVID. Many of these are reversible. And I would also point out that sometimes low vitamin D, low B1, B12, or low thyroid can also be producing symptoms that we would identify as MCI. So it's really important to see your doctor if you are having any of those symptoms of MCI, because it could be something really super easy and that can be, by your physician looking at your pharmaceuticals, looking at your thyroid or your D3, for example. Then you can be able to have some solutions to what you're doing. I can take questions if you hold on just a second. And can you hold it? Hold it. All right. I say hold it because I would forget by the time I get to questions. So pro tip, if you've seen one brain, how many of you seen one brain? Every single brain is different. So how I process my changes is going to be different than how my friend processes their changes, or that person's friend processes their changes. We have some things that are similar, but if we all had the same experience right now, and we go out and 2 of you have a conversation that none of the rest of us have, already those 2 people have a different connectome or brain experience. So we all have constantly a different brain experience. When you compare your person with Alzheimer's or your person with vascular dementia with someone else, it can be very unsettling. If you look at someone's trajectory and you see them barreling through and all of a sudden they got a diagnosis one day and 6 weeks later, the person's in bed and doesn't get out. When we compare ourselves one to another, it can be very disconcerting and uneasy. And it can also create unrealistic expectations. When I see one person, let's say I'm in a social group, and I see one person that's being able to do everything and my person can't do that, then I might come home and say, why can't you be like George? Like, why aren't you like George? Why aren't you doing that? And so it can really cause unrealistic expectations. So remember, if you've seen one brain, you've seen one brain. Major risk factors the biggest one is age. And that is over 65, the risk doubles about every 5 years. And over 85, 1 in 3 people will have Alzheimer's type of dementia. And family history, while it is a risk factor, it is not deterministic. So what do I mean by that? How many of you have heard of 23andMe and how you can get your gene, you could do a gene test for that, right? I did it. My husband and I both did it. I won't tell you who, but one of us had the APO3 or A4 allele, and one of us did not. And so what does that mean? Are we both or either one of us doomed to get it? And the answer is no, it is not deterministic. So it increases our risk factor, but it does not mean that we're going to get it. So anything that we can do to kind of ease ourselves as care partners, we're not doomed just because we have an allele. Then, pro tip. Oh, I just said that. APOE4 gene does not mean that. So other risk factors, head injuries, if you had a TBI in the military, if you had a concussion because on the night that the vice president in 2015 or 2016, whenever it was, when the vice presidential debate was happening, I had gone outside, I fell and bonked my head and got a concussion. So that means a risk factor for me. Overall poor health, things like high blood pressure is a huge risk factor. So you want to control your controllable factors. High blood pressure, your cholesterol, if you smoke, if you have diabetes. Those are all things that are controllable, and those are things that are risk factors for Alzheimer's and many other types, especially vascular dementia. Stress and isolation, believe it or not, stress and isolation are also risk factors. So whatever you can do to keep your stress under control, and we're going to have both Karen and Jane today are going to be talking about ways of mitigating stress. And then isolation. I want every person to repeat after me, and you have to do it because I'm watching you. Isolation is the enemy of our brains. Isolation is the enemy of our brains. It is so easy to get isolated as either a person living with cognitive changes or as a person caring for someone. We have our heads down. We're doing the very best we can to keep everything together. And so sometimes we don't do things with our friends. We don't connect with people that we have been in clubs with, or we stop volunteering, and we stop doing all the things that gave us life and joy before. We sometimes withdraw from everything. But isolation is the enemy of your brain. Also, sensory handicaps. This is really important, especially if you're new to care partnering. Please understand that while you want to help your person get a current eye exam and a current hearing exam. What we know about visual handicaps is that they increase the risk factor. I don't have it here, but I would also make sure that your loved one has regular dental care, because if they have Alzheimer's type, they're not remembering to brush and floss, and that bacteria has been found in the brains of people who have died of Alzheimer's type of dementia. So it's really important. Sensory handicaps are important to correct to the best of your ability, and also making sure people get, I know that sounds like I'm meddling, but even if it's every 3 months, I would even push it to every 3 months, even if you have to pay for it, for dental care, because people do really forget to take care of that. And then finally, poor sleep. It is very difficult to have good sleep when you're a care partner. It is so difficult because your person might be getting up. They think it's time to go to work at 2:30 in the morning. And they're getting up and trying to get dressed, and they're like, where's my car? I can't find my keys, or something like that. And so getting good sleep is tough. But poor sleep is a really super big risk factor for cognition changes. And thanks to the NIH for that. Strategies for healthy brains. Now, I'm telling you this because the people in this room are under extraordinary stress. So I want to give you these tips, not just for the person for whom you're caring, but for yourself, to keep your own brain healthy in the middle of care partnering. Consult your doctor, know your numbers. Try to practice good sleep hygiene to the best of your ability. What is sleep hygiene? It's going to bed at the same time every day, getting up at the same time every day. It's stopping with the caffeine at whatever your body, if you can't have caffeine after 3 o'clock or after noon or whatever, it's being aware of that. And then move your body. Movement is good. The Mediterranean or mind diet, the mind diet is actually a diet that combines Mediterranean and DASH diet. And I'm going to give you a quick slide about that. And then novelty. Do things that are different. Everybody here, not that I want you to be thinking of all of your colleagues here in the shower, but this is a really easy thing to do. So I'm going to ask everybody just for a moment to stand up with me. And you don't have to close your eyes, but I want you just in your mind's eye to picture getting out of the bathtub or the shower. And in your mind's eye, I want you to walk through how you dry yourself off. Because guess what? You have a process. And your brain is so accustomed to it that you do it the same way every single time that you do it. So I'm gonna go through my process with you. So I can't stand to have something on my face. So when I grab my towel, the first thing I do is I pat my face and I kind of like wring out my hair a little bit. And then I used to start with my dominant hand, and I start here drying off, right? And then of course there's the back and the whole shimmy down the back kind of thing, right? And then legs. And then I put my hair in a towel, right? Or something. So you have a system, your own process that you've developed, and your brain has gotten so accustomed to it, it does it without you even thinking. Without a moment's thought, you're thinking about. You don't even have to think about it. Now, did anybody not have a process? No, everybody's got one. Everybody's got a process. Because one of the things our brains, you can sit down now. Thank you. So one of the things our brain does is it simplifies things, and by simplifying things, we do things a lot the same. So one thing you can do for novelty is that you can just change the way you dry off. And your brain is going to go, oh, no, that is not the way we do things. There will be this moment of confusion. It's just this minor bit of confusion, but you'll know because I want to let you know I'm not hallucinating. My brain is not actually speaking to me. But there is this sense that something is not quite right. And what it is novelty in your brain making new neural connections. Also, another great idea for trying this is to use your non-dominant hand to eat one meal a day. And I encourage you not to make that soup the first time you do it because it's not a pretty picture. But novelty is good, and novelty is good for our people living with cognitive changes. So the Mind Diet, this is going to be on your slides when you get the slides, but it's whole grains, it's berries, it's less meat, more beans, having reasonable servings of nuts, not like some of us who, pour an entire bowl and then sit and pick at the whole bowl of nuts, right? But, we do eat nuts, and also green leafy vegetables. They are things that have color and life. You can tell if it's got lots of color, it's probably good for us. And mainly olive oil for added fat. Pro tip, and I want you to think about this. You cannot do everything. There's no way anybody sitting here can do everything. And you can do something. Small, incremental changes. So when we look at the diet, when we think about novelty, when we think about what coulda, woulda, shoulda, we just make small incremental changes. We don't have to do everything. And if you're looking at your diet, maybe for 1 week, I say, okay, this week I'm going to add a piece of fish. And maybe next week I'm going to add some more green leafy vegetables. But you don't have to do it all at once, right? So questions. Now we're ready for questions. Rena, you had something.
So can depression also be a cause of MCI that could be reversible? When you see a person that's been living with depression for a minute and they're displaying kind of memory kind of issues, and could that also be?
Yes, is the answer. So let me repeat the question. Rena was asking if depression can also be a cause of reversible dementia. And it absolutely can. And there are some neurocognitive tests, neuropsychological tests that can, thank you so much, Karen.
Oh, sure.
There are neurocognitive tests that can be taken by someone that can sort that out or tease that out, whether it's depression or whether it's a clinical dementia diagnosis.
Okay, who do that? Would that be like
A
primary or?
So the primary, or who would do that test is the question, and the answer is it's typically ordered by the primary care physician or the neurologist, and it's carried out by usually a PhD level clinical neuropsychologist.
Hi, on your tip slide, it seemed you were, maybe inadvertently, speaking to us. So the question is, are those also good tips for our partners who may have advanced Alzheimer's, for example, novelty? Or would that be on the frustrating side and, as you said, expecting too much? Thanks.
So yes is the answer. So some of these are things that we can translate into care for a person. Novelty is a great example, having good food, moving our bodies. Even if you've got somebody who's sitting in a chair and they don't want to move, sometimes we can just get them to cross knees, just sitting there, do right across their knees, left, right, brain integration, and we can get them to move in some way. So yes to that, yes for you too. So much of the pro tips can be used for either the person living with cognitive changes or yourself.
I just want to say that it should be cautious about the MCI because my wife was diagnosed with MCI, and within a year she had deteriorated, and actually the neurologists couldn't believe it. Basically, they were stunned at that change. You can be fooled by somebody who's a very high-performing person, and they can cover a lot for a while, and that's unfortunately what seemed to happen.
Thank you. You make such a good point. In what we do find is that in people that have a lot of cognitive reserve, people who have read a lot or had a lot of education or are the smartest people that you've ever met or can take apart an engine and put it back together with their eyes closed, sometimes with these kinds of issues, you'll see that people have cognitive reserve and they can hide it for a long time. And so a lot of times care partners will get to a certain stage and say, I'm just trying to be mindful of the time. get to a certain stage and they'll say, I realize now that what I saw like 8 years ago, that was actually the beginning of this, and I didn't notice it. But in retrospect, you can see it. And I think it kind of protects us to some extent as care partners, because I know when, and I'll just briefly tell you what brings me to this work to begin with, is that I had a father with a diagnosis of Alzheimer's that I got after a fall. He had COPD, and we thought that when he was confused a little bit that it was hypoxia. He wasn't getting enough oxygen to his brain, right? And so he fell and they gave him an MRI, and it was a resident. It wasn't an attending physician, but a resident came in and said, other than the Alzheimer's, everything is just fine. And so my dad had Alzheimer's. I didn't know, at that time I knew absolutely zero about it. And so a lot of times these things come as an adjunct to some other kind of illness. And it could be that illness, like sometimes people have have congestive heart failure alongside cognitive changes. So they can go alongside, but also, as I was saying, sometimes, these diagnoses can be really elusive.